All right, I think I have it up and running. I think so. Fantastic. Let's get started. Hello, welcome to Ice Rounds. My name is Dave Young. I'm one of the new Wilderness Fellows at the University of Colorado, and I have the privilege of giving you guys a lecture on dive medicine. I love dive medicine. I am not an avid diver, but I've been diving for probably about the last 5 years or so. So I've gotten some experience doing it. I think the physiology of it's really fascinating, and it's definitely the crux, one of the crux of wilderness medicine. So I know that there's not a whole lot of diving that's happening in Antarctica. I do hear that there's a team or there's a group of people who do some dives. So you may come across some of the injuries related to dive medicine, but I do realize that it's not incredibly pertinent. So hopefully it's just interesting and fascinating and builds on your wilderness knowledge. But let's go ahead and get started. Let's see if I can make this guy work. There we go. All right, so we're going deep into the deep blue. I realize that this is a nice picture of people. It looks like so we're kind of tropical, but really, let me drag this picture up here. This is probably what it looks like in Antarctica. Some guy just in the cold, freezing water in a dry suit. But we're definitely going to go into the details of dive medicine, and so you feel very comfortable treating disorders of dive medicine and know what you're looking for and where to go and what resources to find. But let's start with the objectives. So we're going to go over we're going to talk about the overview of diving physics. So physics are very important for dive medicine, I think even more so than altitude. I know you've already had a lecture on altitude, but for the physics for dive medicine is incredibly important. So we'll go over that, as painful as it may be. Pathophysiology of diving medicine, barotrauma, decompression sickness, and overpressure syndromes. So we'll cover those. The last three are the disease states of dive medicine, so we'll be going over those in some detail. All right, let's start off with the case. So there's an overweight diver in poor physical condition. He returns to diving after a hiatus after several years. He pulls his old gear off the shelf and attempts to dive at 80 feet. The reef that he's diving on is has very strong currents. He burns through his oxygen very quickly, trying to stay afloat or stay in the same plane, and he realizes a little too late that his oxygen is running out. He has to make a rapid ascent, and unfortunately, he is found unconscious and pulled from the water by fellow divers. So we'll think about this case as we go through the next topics, and we'll readdress this case at the very end. There's 4 reasons why divers die. The first is poor diver health, general lack of fitness. There's pre-existing cardiovascular disease that might be noted and oftentimes cited in many fatalities. There's procedural errors. People have trouble with their buoyancy. Sometimes they have rapid ascents, missed decompression stops, and then failing to monitor the oxygen supply, like our diver that we just talked about. Emergency ascent is cited in 26% of all deaths. There's also environmental issues. Temperature, definitely a factor in Antarctica. Depth and currents. Rarely, there are animal attacks for divers. There's been very few documented, but there are a few. It is possible, and I would consider that an environmental issue. And then there's also equipment problems, and that's pretty obvious. Failing of the mask leaking, or the regulator just stops working, or the oxygen tank breaks, or something. No good. So how common is diving? There's actually 4 million recreational divers. At least this was 4 million in 2008. I'm sure it's probably 5 or more now. There's many more internationally, of course. 400,000 new certifications annually. I believe that's by PADI. And then there's PADI is like the they do all the certificates for diving, if you don't know them. And then there's a couple other companies, but PADI's the biggest. And there's 1,200 reported cases of DCS, which is decompression sickness, that was noted in 2004. I don't know why the statistics is kind of old. That's all I could find. So there's several different diving types. One is breath holding. That's in this picture here. I guess in 2007, someone had a record of 704 feet, which is absolutely insane to me. I don't understand how somebody went 704 feet under the water with one breath, but apparently they did, and they're alive. Scuba, and that's probably the most common. Most people who are going to be going underwater are scuba certified and recreational. Does anybody know what scuba stands for? If you can think in your mind, you can ask each other if you're watching it with other people. But it's self-contained underwater breathing apparatus. So pretty good acronym, I think. There's also surface applied air. You'll probably, if you can think back to the super old like Jacques Cousteau time period where the people have these like metal hats with this like little window and a big tube going to it. So the air is being supplied by it's just from the tube, from the surface of the water. People they actually still use these mechanisms, but it's mostly for like construction and things like that, underwater construction. There's it's called saturation, which is living underwater. It's like people live in like this bubble or a construction that's actually below the surface of the water. And then there's something called ATA diving. It's a one-person submarine. So these are some of the ones that I've come across for different diving types. Again, scuba being the most common. So physics of the underwater environment. As painful as it is to remember physics, it's very important for underwater diving or for dive medicine in general. So pressure equals force per unit area. You may remember this. And there's multiple different units that you can find with pressure. Atmospheric pressure, 1 atmosphere is at the sea level. It's also equal to 760 millimeters of mercury. That's also very closely the same thing as Tor. I think Tor is just a little bit more like 760.1 or something different, but Tor is almost the same thing as millimeters of mercury, 14.7 pounds per square inch, and as well as 1 atmosphere is almost the exact same thing as 1 bar as well. For all the scuba equipment, the actual pressure gauges are going to read 0 at sea level, and you can see in that little picture down at the corner that it reads 0. Physics. So each foot of seawater adds 0.44 pounds per square inch of pressure to the atmospheric pressure, which is 14.7 if you remember. And every 33 feet of seawater, FSW, is 1 atmosphere. So if we're at 33 feet of seawater, it ends up being 2 atmospheres. So if we think what would be the atmospheric pressure at 99 feet, you would answer 4. So 1 for the surface, and then 33, 66, and 99 with the surface. 4. Great. So the change in pressure is linear, but the greatest relative change, basically because we're talking about volume, is near the surface. We'll get a little graph. Oh, is that? Did I miss the graph? No. There's a graph in a little bit that we'll talk about. So this is also this graph helps us understand kind of the pressures and then the depths. So they're equal. Those are linear things. And then we'll see the gas bubble volume. Now we're talking about volume, which is in a sphere, is like 4/3 times pi radius cubed. I actually don't really know if that's completely certain, but it's something like that. I think it's like trigonometry or something. So that's why the numbers aren't particularly linear, but quadratic or actually exponential. And so you can see that there. Great. So physics laws, these are painful to remember, but there's Pascal's law, an important one. It says that pressure applied to any part of a fluid is transmitted equally through the fluid. So fluids are not very compressible, so it's like a solid. So it's just like hydraulics. If you push against a hydraulic, it's going to move something on the other end. Whereas gases, that won't necessarily be true. So gases are quite compressible. You squeeze them in, and then just the molecules get closer and closer and closer together. The pressure gets greater, but the volume will actually decrease. And that's what Boyle's law gets at. The pressure of a gas is inversely related to its volume. If you see that the PV equals K, so that equals pressure times volume equals a constant, and K is the constant. So pressure, if you divide by volume for both sides, so it'd be P equals K over V. So you can see that pressure and volume are inverse, and it's logical as well. As pressure increases with descent, the volume of the gas will decrease, and then it's the opposite. As pressure decreases with ascent, the volume of the gas will increase. Does that make sense? And then it's not necessarily it's not linear. It looks a little bit more like this. So we can see that as you go up in pressure, the volume, that volume down here will actually decrease. So like up here. But if you increase the volume, then the pressure will decrease. All right, got that concept. It's pretty crucial to understanding what happens to our body. So most of the body acts as a liquid because most of our bodies are liquid or solids. There are some gas, of course, in our bodies as well. That includes our lungs, middle ear, sinuses, GI tract, as well as dissolved gases in our liquids, just little microscopic gases. And dysbarism, which I'll never use outside of this lecture, I don't think I've ever heard this term before giving this lecture, refers to the pathology related to volume or pressure changes experienced while submerged. This also pertains to space as well, since there's pressure changes in space. We're going to talk now about diseases of underwater medicine. Barotrauma is a problem of descent. There's also problems of just being at depth, and we'll talk about nitrogen narcosis as well as oxygen toxicity. There's problems of the ascent, decompression sickness. You may have heard that being referred to as the bends, or pulmonary overpressure syndrome. So we call that POPS. All right, let's go ahead and get started. Let's talk about barotrauma. So I'm going to get a little more comfortable. The couch is not digging into my side here. So barotrauma. So pressure in air-filled spaces of the body is in equilibrium with the environment. So that's why right now in breathing normal sea level or mile level, because I'm in Denver, air, it will, in my eustachian tubes and in my sinuses, everything is in equilibrium. It'll just kind of move back and forth. Once there's a blockage or an obstruction, maybe my sinuses are blocked, or maybe my eustachian tubes are swollen, or maybe I'm underwater and there's a water seal, and the seal of water is preventing any type of equilibration of gases. So otherwise, normally we would just equilibrate. And barotrauma results from the inability to equalize pressure, and it is our damage of our tissue. It's the most common medical problem in diving. Some of the examples are mask squeeze, ear canal squeeze, which is also called, which is just pain in the ear canal, barotitis media, which is on the inner ear. There's barodontalgia, like pain in your teeth, because you might have a little bit of air at the very base of your teeth. Suit squeeze, which is when you have air in your suit. Lung squeeze, and GI barotrauma. And we're going to talk about most of these, at least the pertinent ones. Barotitis media is quite common ear squeeze. It's not ear canal squeeze, it's just ear squeeze. The TM is actually deflected inward, sometimes to the point of rupture. It's the most common diving medical problem. 30% of first-time divers actually experience some of this, and 10% of experienced divers still will have some barotitis media. It presents with acute onset of ear pain, possibly associated vertigo and conductive hearing loss. And if you think about what's happening in the middle ear, what's happening is as you go down, you have a certain pressure in your ear at sea level, and as you go down with pressure, with depth, you're going to increase the pressure, and so the volume inside your middle ear is going to decrease. So the volume's decreasing, and your TM is being deflected inwards, and that can cause a lot of pain. Obviously, it can even rupture. So you may, someone complains of severe ear pain after a dive, you might look in their ear and see this little picture on the bottom there of a ruptured and bloody tympanic membrane there. Sometimes it's seen just at 2.5 feet. So if someone's really having trouble kind of equalizing their pressure, even at 2.5 feet, you can actually start having some deflection of the tympanic membrane and have some discomfort. It's preventable. What you do when you dive is if you're not divers yourselves, you basically kind of squeeze your nose and blow out, and you can push air into your middle ear cavity, and it can equalize the pressure by doing that. If there is eustachian tube dysfunction, like from upper respiratory tract infection, like swelling or allergies, or someone's just a smoker and they have some dysfunction, they should refrain from diving, because if you can't clear your ears, then you can end up with that tympanic membrane rupture. There's a Teague classification to describe the degree of damage. I have to look down here. I can never remember, but I have some notes at the bottom. So type 1 is basically just retraction. Maybe you might see some redness. Type 2, you'll see definitely some retraction, and you'll see significant redness over the eardrum itself, the tympanic membrane. Type 3, you'll actually see hemorrhage and possibly fluid or blood behind the tympanic membrane. And type 4 is perforation and hemorrhage, like we saw in that last picture. All right, barotitis media before diving, and someone's complaining of some mild symptoms, and they really want to try to go. You can try to give them some oral or nasal decongestant, some antihistamines. There's some nasal vasoconstrictors like Afrin, or some nasal steroids like Flonase. You could try those and see if the patient starts feeling better, and you could give it a trial. But I would recommend that if they feel like they're not clearing their ears appropriately, that they should not go, continue to go, or definitely not go any deeper. And you should not dive until these symptoms are resolved, of course. Antibiotics antibiotics are sometimes used when you have barotitis media, but only when the tympanic membrane is ruptured. Typically, when people have barotrauma from, let's say, a blast explosion, the eardrum may be perforated, but you wouldn't typically give them antibiotics. Because people are in salt water and there's potential saltwater contamination of the middle ear, that's why we would actually do antibiotics for them if there was some underwater rupture. So let's talk about inner ear barotrauma. It's a little bit different. This occurs from very forceful Valsalva or very rapid descent. So people really pushing some air into their middle ear canals via their eustachian tubes, or very rapid descent that can damage the oval or round windows. The oval window oval window is part of the semicircular canals, whereas the round window is part of the cochlea. Those are small little discs, very similar to the tympanic membrane, but much smaller. Symptoms are a roaring tinnitus, so very bad ear ringing, vertigo, hearing loss, and feeling of fullness in the ear. They can have nausea, vomiting, vertigo, maybe some ataxia or changes in their gait. It's usually associated with middle ear findings, the tympanic membrane rupture. Hearing loss is always present. Initial therapy is bed rest. You raise the bed to 30 degrees and you give them some analgesics. Steroids may be helpful for the tinnitus. And if there is persistent or progressive symptoms, it may mandate an ENT referral. There's also something called inner ear decompression sickness, which we'll talk about a little bit later. It's different symptoms, and we'll get to that. Another symptom is mask squeeze. So this is actually a compartment of air that is not part of our body, but is made by the mask, between the mask and our eyes. These people look like scary vampire people, and would probably be a great, Halloween costume if you wanted to make yourself have mask squeeze, but I wouldn't advise it. So what happens is basically the mask pressure is normally maintained by nasal exhalation, so you don't get the mask squeeze. But if you think about it, if you go underwater and you go really deep with a certain amount of volume of air in the mask itself, if you just keep going down without any repressurization or equilibration of that pressure, as you go deeper and deeper and deeper, that there's going to be a pressure and pressure and pressure on that volume of air, and it's just going to get smaller and smaller and smaller, and that's going to result in basically suction, and it's basically going to suck the eyeballs out of your head like it looks like to these guys. It's not particularly dangerous. It usually resolves okay, and I don't think the eyeballs actually ever come out. Barosinusitis, this is sinus squeeze, same mechanism. What's happening is now a vacuum in the sinuses, so you have maxillary and frontal sinuses, and it basically sucks like all the you get this venous congestion in the epithelium lining the sinuses. It can lead to pain and bleeding. You can treat symptomatically. You can see this guy, he's actually having like a nosebleed from his sinus squeeze. Don't have that around sharks, I guess. Okay, changing gears, we're going to move on to nitrogen narcosis. These are diseases that happen at depth. So let's talk about inert gas narcosis, because normally we talk about nitrogen narcosis, but technically it's an inert gas narcosis. Let's talk about Henry's law is an important thing. I will read it out to you. I have another note at the bottom of the screen. At a constant temperature, the amount of given gas that dissolves within a type and volume of liquid is directly proportional to the partial pressure of that gas in equilibrium with that liquid. That's a lot of words. Basically what happens is as you go further and further down with increased pressure, you're going to increase the partial pressure of that gas, and it's going to increase the dissolved gas in the fluid. So there's just going to be an increased partial pressure of that gas in the fluid. The increased pressure you go. So in those gases, we'll back up to helium. So except for helium, all gases actually have a narcotic effect, widely varying in degree, and we'll have a little chart, I think the next slide that'll show us the degree of the variability. But helium, again, has pretty much none. Those gases with a higher lipid solubility have a greater narcotic effect. Divers may learn to cope with the effects of nitrogen narcosis. They may know how to kind of deal with it a little bit better, but there's never any tolerance that occurs. narcosis affects all divers, although susceptibility varies widely from dive to dive and between individuals. It's a little bit like acute mountain sickness, how even with one person who goes to the same altitude like a month apart, and they can have completely different symptoms. One day they can feel terrible, and the other day they feel absolutely fine. There's a lot of factors that play into that. So same thing with nitrogen narcosis. So it's called Rapture of the Deep. Bonus points for anybody who remembers who knows who said that. I can't call on anyone, obviously, but it was Jacques Cousteau who said that in French, of course. But he called it the Rapture of the Deep. And it's named because nitrogen is the prominent gas in compressed air. So when we breathe air at depths, what we're doing is we're just breathing compressed air. We don't typically breathe 100% oxygen. It's just typically compressed air. And 80% of that is nitrogen, and so that's the main component. We can see that the relative, over here on the chart, the relative narcotic potency, I can use a mouse, which is, we labeled nitrogen as just 1.0. We actually can see that oxygen is even more narcotic, having even more of a narcotic effect, which is interesting. Helium, again, has pretty much nothing, and xenon, way down here, actually has quite a significant effect. It's not quite as high as things like halothane or sevoflurane. Those are two anesthetics that we use, gases that we use to induce anesthesia for surgery. Xenon actually used to be used for surgery and would actually put somebody out pretty easily. They stopped using it basically because it's a little bit dangerous, but it's also expensive. Little interesting factoid. So if we look at this chart here, we can see that as we go down in depth, we'll see some of the symptoms that can happen because of nitrogen narcosis. Usually at a depth of 10 meters, you're not going to really have anything. By 30 meters, you may have a little bit of euphoria. By 50 meters, which is about 160 feet, that's pretty deep, you start having some significant effects. So calculation errors, idea fixation, you can have some overconfidence, a feeling of well-being, and delayed response, just like as if you're drunk. In fact, many people feel like nitrogen narcosis is like feeling drunk. Some people have called the scale the martini, or the law, maybe the martini law. That's because if you look at the bar on the left column, so the pressure, or these are really roughly equivalent to atmospheres, for every atmosphere that you go down, it's equal to drinking one martini. So if you are down to 160 feet, it's almost like drinking 6 martinis. And I'm a bit of a lightweight, but that would make me feel quite nitrogen narcosed or drunk. So if you think about going even deeper, so 300 feet down, you'll see that that's like 10 martinis. That's quite a lot. So that's concerning. You can get some hallucinations, unconsciousness, death from nitrogen narcosis. So it is a dangerous thing. In fact, people even at lower altitudes, or lower depths, even here, may just do silly things like take their regulator out of their mouth, or just kind of swim upside down, or get a little bit lost and have some problems. Okay. All right, nitrogen narcosis continued. So it fully resolves with ascent. So it completely is reversible with no lasting effect. So there's no hangover here. Once you get up to the surface or get even higher, you'll breathe off this nitrogen, and you'll no longer be drunk. To prevent it, it's recommended that you dive, especially if you're not an experienced diver. You don't dive any further than 30 meters, about 100 feet, and really there's very little to be seen much further down than that. Depends, but if you're just a recreational diver, you probably shouldn't be going further than 30 meters for safety reasons. There are things, if you were going to go below 100 feet, to use gas mixtures. These mixtures have mostly just helium in it. So, and the helium, like we saw before, has a very little narcotic effect. So as you replace the nitrogen with the heliox, or the helium, and that basically prevents narcosis from happening from the nitrogen. All right. Let's talk about oxygen toxicity. This is a little bit different. This relates to breathing in very high partial pressures of oxygen, or high concentrations of oxygen. It actually can cause harmful effects, sometimes just chemical effects on your lungs, and sometimes you can actually get damage due to free radical formation. So there's two main things that we'll talk about in oxygen toxicity. One is pulmonary toxicity, the Lorraine-Smith effect, and then CNS toxicity, the Paul Burt effect. And we can see that high inspired oxygen pressure will kind of skip everything here in the middle. As you can see, there is some like myocardial damage, some renal damage, endocrine effects. There's things that you can cause damage to your retina, retinal detachments. So there's things that happen with oxygen toxicity. What we're going to focus on is more this side here. Oh, low battery. Oh shit. I think I have too much of a lecture left to not. I'm going to grab my battery. Okay. Or my cord. Grab my cord. Sorry, look at the graph. You're seeing yourself with the graph. I don't even know where our plug is around here. Oh, yes. So on the left, we can see the lung issues that you can have, and then on the right, you'll see the CNS effects that we can have. All right, plug on. And well, not a Boy Scout, definitely not always prepared. My bad. Okay, good to go. All right, so next. All right. So pulmonary toxicity, so breathing high partial pressures of oxygen for long periods of time causes actually like a chemical irritation of your airway. If here it says 1.0 ATA is like another term for atmospheres. So if someone just breathed from a non-rebreather, not even from a non-rebreather, but like a BVM. So if they had a BVM where oxygen, just pure 100% oxygen was coming in and CO2 was going out, they could last for about 20 hours before they start developing pulmonary toxicity. But that time changes if you breathe 100% oxygen at an atmosphere of 2 atmospheres, then it only is 6 hours. And so if you can imagine that at 5 atmospheres, you're not going to last very long if you're breathing 100% oxygen. Granted, it's usually only 20% oxygen that we have in our tanks, but just the concentration in air. But again, it can happen, pulmonary toxicity. And it just says quickly a note saying you can prolong this time by taking even just 5-minute little air breaks. And that's mostly when you're at sea level and you can come off the oxygen. Pulmonary toxicity symptoms include substernal discomfort on inhalation, can feel like a burning discomfort, persistent coughing, and it can actually lead to a loss of lung vital capacity. I don't believe those are permanent effects, but just while everything's kind of inflamed and angry. CNS toxicity, this occurs at 2 atmospheres or higher, or deeper rather. I didn't finish my thought there, but the duration, I'll clarify, the duration of for CNS toxicity is less important than actually depth. So the deeper you go, the more likely you are to have CNS toxicity, whereas for pulmonary toxicity, it's more about how long you're exposed to the oxygen. Obviously both depth is a factor in both situations as well as time. So CNS symptoms, you can have some kind of nervous symptoms, muscle twitching, seizures. Seizures obviously are very dangerous if you are having that at depth, because if you seize it underwater, you will likely die from drowning. Treatment is to just lower the oxygen exposure, so decreasing the oxygen load that you're having coming to you. Okay, so let's get to decompression sickness. This is a bread and butter thing for dive medicine. It's also called the Benz, or sometimes caisson disease. It's a common diving problem. It's caused by formation of inert gas bubbles in the blood. It also can be in the blood as well as joints and muscles and other tissues, but mostly we think about it in the blood. We're going to refer back to Henry's law, which explains that at increasing pressure, you'll have an increased partial pressure of a gas, and that'll lead to increased dissolved gas in the tissue and in the fluid. And I have a little picture of Radiohead The Benz. It's an awesome album. It's really old. It's like the 80s, I think, early 90s maybe. But it's really fantastic, and it's called The Benz. Awesome. So decompression sickness, multi-system disorder caused by rapid decrease in atmospheric pressure. So as people come up, they're decreasing the atmospheric pressure, and the faster you do that, the more likely you are going to have decompression sickness. These inert gas comes out of solution forming bubbles in tissues and blood. So as you go up, the decrease in pressure causes the volume to increase, and so those bubbles get bigger, and they can get stuck in tissues, in joints, and in little capillaries. In addition to these mechanical effects, actually the bubbles can activate the immune system, cause quite a lot of inflammation, as well as trigger the coagulation cascade. Lots of effects that they can have. What I was surprised when I was doing this presentation, I remember learning about decompression sickness a number of times, but I never realized how late it can occur. I was surprised to find that only 50% have the symptoms by 1 hour, and 90% by 6 hours. Again, by 24 hours, you should be completely fine from decompression sickness. You can't imagine you would have it by then, but it is something to worry about and to consider. But again, even by 6 hours, there's still 10% of people who are going to still have decompression sickness. The incidence is about 1 in 4,000 dives, not divers, but dives. That actually happens. There's two different types of decompression sickness. The first is musculoskeletal. This is classic bends, where someone has poorly localized joint pain, rash, itching. It's called the bends because people are like bent over in pain. It can happen to any joint, but the shoulders and elbows are the most common, and movement worsens the pain. If you actually had somebody come to you and be like, oh, my elbow is really kind of sore, I just did this dive, maybe it was from swimming, maybe it's the bends, you actually could put a cuff. You could inflate it to about 200 millimeters of mercury over the joint itself, and what you're doing is you're just increasing the pressure, you're decreasing the volume of those bubbles in that joint space with that pressure, and it should actually, they'll feel a squeeze, it's not going to be a comfortable squeeze, but they actually should feel that achy joint pain go away. There's another thing called milking as well, which actually increases the pain, kind of pushing these bubbles towards the joints. I don't really recommend that for obvious reasons. So we're still on type 1 DCS, still musculoskeletal. You can get this itchy mottled rash. The itch is mild, but it can be a bit itchy. It's called cutis murata, and it looks like this. It's kind of this like modeling of a rash. It will go away. It takes a few hours to go away, but typically goes away after the onset of the symptoms. It's usually associated with pretty significant bends, as well as, interestingly, a PFO, patent foramen ovale, which is a little hole that can transmit clots or bubbles from the right side of the heart to the left side of the heart. Otherwise, the bubbles and clots would get stuck in the pulmonary vasculature, and they wouldn't end up getting to the left side of the heart. But if you have a PFO, it can actually go to the left side of the heart and go to the rest of the body via the arterial system. And it's a harbinger for more serious symptoms that may end up happening later. So when you do see something like cutis murata, you might as well have a good suspicion and consider recompression therapy. Let's talk about the type 2 decompression sickness. This is mostly neurological. There's a couple other types we'll talk about, but the main concern is neurological. Cerebral involvement is 23%, whereas spinal cord involvement is, what would it be, 77%? It results from an arterial gas embolism. So little bubbles will be in the arterial system. They'll go to the brain and can cause some cerebral symptoms. We'll talk about in a second. However, the spinal cord involvement they think is related to the venous system, causing flow backup, and cord infarction actually can cause some pretty significant findings. The symptoms may be progressive. It may just start with a little back pain or some dizziness, lead to some weakness, and then actually numbness and paralysis. It doesn't always have to follow a nerve pathway, and we can see here on the MRIs, you can see, look for the arrows, there's a little bit of signal abnormality here in the spinal cord, as well as here, and that's actually the neurons actually dying from this type 2 decompression sickness. So very serious and with some permanent effects. A couple other types of type 2 DCS. So these are, again, a couple more severe ones. You'll get pulmonary DCS, also called the chokes. It's a rare condition where there's a massive pulmonary gas embolism. So from the venous system, you'll get a lot of bubbles, a lot of gas that'll come together and create this large pulmonary gas embolism that'll lodge itself in the pulmonary vasculature. causing a lot of substernal pain, cough, and could cause cardiovascular shock. There's also inner ear DCS. I referred to this a little bit earlier. That we were going to come back to this. It's called the staggers. This is when bubble formation occurs in the semicircular canals, and you can have acute vertigo, nystagmus, tinnitus, and nausea, vomiting. It's a much more severe manifestation rather than just having like an oval window or round window kind of rupture or disorder from barotrauma. This is actually like air's in there and it's causing a lot of discomfort and pain and severe neurologic symptoms. Treatment, the first thing is to remember a diving buddy. It's been shown that larger groups who dive together tend to have lower rates of DCS, mainly because everyone's kind of checking in, everyone's on the same thing, and people are slowing down, and people tend to go a little less extreme, and rather than their buddy and try to see everything and go up and down and whatnot. So you try and do recompression as soon as possible. That'll help with the pain, and then of course for type 2 DCS, for all of those neurologic and other symptoms, recompression is absolutely necessary if possible, if it's nearby. You should give them 100% oxygen in the meantime, and you can try NSAIDs or aspirin. Both are commonly used, but lidocaine and steroids are not recommended. Pulmonary overpressure syndromes. This is another problem with another disorder when you're ascending too fast. There's 3 different types of POPs: mediastinal emphysema, pneumothorax, and arterial gas embolism, the last being the most dangerous. All of them result from the expansion of gas trapped in the lungs. So on ascent, there's gas that actually ruptures the alveoli. If you think about it, if you are, let's say you're 30 feet under the water, and you take a really big deep breath, you fill your lungs with air, and you go up to the surface. You're going to think what's happening to the volume in your chest wall. The volume's going to continue to you already took a big deep breath. There's not a whole lot more room where the air can go. But when you go up, the volume's actually going to continue to contract and actually could burst through your pulmonary lining. So it often happens from rapid or uncontrolled ascent to the surface. And again, maximal lung volume held during ascent is a precipitating factor. Shallow depths are the most dangerous. If you remember from that graph we had earlier on, because of that little, or actually for you guys it'd be that way, I think. The changes in volume are actually the greatest at the surface. So shallow depths are the most dangerous, and deaths have occurred from depths of 6 feet, which is pretty surprising because it's not very deep at all. You can have mediastinal emphysema. It's also called pneumomediastinum. It's the most common type of POP, so you can just get a little bit of air in the middle of the chest. You can also have subcutaneous emphysema, which is some basically trapped air under the skin. Symptoms include hoarseness. What? Oh, sorry. I'm not hoarse. I'm just yawning. Sorry, I need to go to sleep. Sometimes the air can track up into kind of the compartments of the neck, causing some hoarseness. You can have some substernal chest pain, some dyspnea, and some, like I said, neck pain. Radiographs are confirmatory, although they're a little bit tricky to read. A radiologist with a nice screen is helpful. Treatment is conservative. There's not a whole lot you can do for it. Let's pull up this X-ray. So you can see here with a white arrow, this is not normal. This area of lucency there, looks like there's a little bit of lucency in there on that side as well. That's signifying pneumomediastinum, and then up here by the black arrow, that looks like that's representative of subcutaneous emphysema. All right. Speed it up. Here we go. All right, pneumothorax. So it's rare because it's actually hard to rupture the visceral pleura to get air in there. And those with blebs are more susceptible. Those are like little pockets of air that some people just genetically have on the very outskirts of their lungs. And you can imagine those blebs never really never get equilibrated, and so different pressure changes, especially at depth, could actually like rupture those. So that's really dangerous. Someone who's had bleb in the past or spontaneous pneumothorax should never dive. You should treat it as a standard pneumothorax. You put a chest tube in, you put a pigtail catheter in, whatever's appropriate. And if you actually think if the pneumothorax, the PTX, the pneumothorax occurs at depth, decompression could actually cause a tension pneumothorax. So if you're thinking, let's get this guy up. So if you're thinking that at depth you rupture through some of the lung lining, air escapes into this potential space here, and it stops. But if this potential space as you go up is going to expand, and that could just completely shift. It can create a tension pneumothorax, shift this lung down, completely collapse it, shift the mediastinum over, maybe shift the trachea over, and that's obviously concerning thing to find. Okay. Arterial gas embolism. This is the most feared complication of POPs. Very dangerous. It results from rapid decompression, so coming up very fast. And what will happen is air will rupture the actual pulmonary vein. So rather than just the lungs themselves, the pulmonary veins travel through the lungs, and these are headed to the left side of the heart. They're just like veins. They have kind of a thinner wall. And so they're traveling back to the heart, and you can actually rupture them, creating a lot of air emboli that travel into the arterial system. So into the left side of the heart, and then the left ventricle will just pump it out to the rest of the body. It travels to the aorta and to the brain, to the heart, to the kidneys, to every other area of the body. We worry most about it occluding the blood flow to the brain, compromising the blood-brain barrier, and resulting in stroke-like effects. Never good. Almost all cases present within 5 minutes, so it's a very quick onset. Again, it's happening from rapid ascent, so where you tear these vessels. Otherwise, in the lungs, the oxygen actually equilibrates pretty fast otherwise. Some of the symptoms, you can have stupor or confusion, coma with or without seizures, visual disturbances, vertigo, general neurologic kind of problems, as well as cardiovascular collapse. Fortunately, cardiovascular collapse only happens in about 4% of people. Treatment for arterial gas embolism, ACLS, so advanced cardiac life support. So if the person is dead or near dead, ACLS is appropriate. Obviously, supplementing them with oxygen. You should immediately refer them for recompression to reduce that bubble volume that's traveling to their brain or to other areas of their body. Nothing should delay this. You should make this happen extremely fast, if at all possible. And if you need to evacuate by air, the patient should stay below 500 feet if they're being transported in a helicopter. There used to be an old adage that the patient should be held in Trendelenburg position, so head down. That's been disproven, and the patient should just be held in supine, just flat position, face up. This is a hyperbaric chamber, so this is where someone would go if they had a decompression sickness or POPs. We could put them in there, and usually we usually pressurize them to about 60 feet and monitor them. You can see like there's little windows in here, and you can monitor them. You actually fit several people in this one, which is nice and big. There's also portable chambers where it looks like there's a little child and a woman in there, so maybe multiple people, but usually made for one person. Maybe if you're going to a very remote place like Antarctica, and there's no dive chamber, you guys even may have a portable chamber just in case for decompression or POPs. So contraindications to diving, there's some absolute ones. Seizure disorder, you should be seizure-free for 5 years before you ever dive. Asymptomatic coronary artery disease, you can imagine that someone's kind of, swimming along against the current and feeling some angina and being like, I don't know, I don't feel so good. That's probably a bad place to have a heart attack. So symptomatic CAD, no. Previous spontaneous pneumothorax, like I mentioned before, or bullous lung disease, that's similar to having blebs, but a little more severe. And I found that having insulin-dependent diabetes is a little bit surprising, but the rationale was that people underwater sometimes can exercise a little bit more, may have gotten their insulin dosing wrong, and actually become hypoglycemic, a little confused, and maybe even seize. And if you seize underwater, you die. So that was absolute contraindication. Some relative ones, like I mentioned before, having an upper respiratory tract infection, nasal congestion, or sinus disease, being pregnant, being physically unfit or obese, having a history of POPs is a contraindication. COPD and asthma, if you can imagine, these are obstructive pulmonary conditions. So what the problem is, air gets in okay, but the air has a really hard time getting out. And you can imagine that if you're ascending, you're having a hard time getting air out. You may actually develop develop POPs because you're ascending, but you're not actually getting all of the air out to decrease the pressure there, and the volume may just get bigger and bigger and bigger and pop your lungs. A PFO, so patent foramen ovale. So that'd be worrisome because the air bubbles will come out of solution in the venous system more readily than in the arterial solution, given the pressures of the system. So the venous system being much lower pressure than the arterial system. So larger bubbles will form in the venous system, and if these larger bubbles head over to the arterial system, they can actually like swim right through the PFO and head right to the brain, causing negative consequences. And of course, people with anxiety disorders or claustrophobia is a relative contraindication as well. A lot of people panic underwater. It's a scary feeling sometimes, having to breathe through a little regulator, having a mask on your eyes, or maybe you see a shark or some other animal that is frightening. So having an anxiety disorder on top of that is a relative contraindication. Air travel guidelines, we touched base on this really quickly. The last comment on there, you shouldn't evacuate a patient. If you're going to evacuate a patient, keep them less than 500 feet above ground level. Airplanes typically pressurize their cabin equal to an elevation of about 6,000 to 8,000 feet. So people, if they travel to, let's say, Belize or Zanzibar for a dive trip, you don't want to just get on a plane, like dive, all day, and then be like, oh, got to catch my flight at 4 p.m. Because again, once the decompression sickness can take 12, 24 hours before it even sets in. So it can easily make it worse when you go up in elevation. So obviously, making the atmosphere 8,000 feet of elevation is I forget how it's about maybe a half atmosphere, not quite, but atmosphere is. It's like 3/4 of an atmosphere. So it just decreases the pressure even more. So could precipitate decompression sickness. If you had dives requiring compression stops, you should wait 24 hours before boarding a plane. So back to the initial case, like I said, we were going to. An overweight diver who was in poor physical condition basically uses old gear, dove at 80 feet, used up all of his oxygen swimming against the current, and had to make a rapid ascent. He is pulled from the water by fellow divers and he's unconscious. You're the only medical professional. Everyone's turning to you. They're like, what is going on? What do we do? So think really quickly in your mind, what's the differential for him? And for that differential, what would you do? So think really quickly about that. In my mind, what I would think is, I could answer it probably on Thursday when we talk. I'll just answer it now. I won't keep you guys probably are. You guys know. So most likely this is an AGE, so an arterial gas embolism. That's the most concerning thing that comes to my mind. So we would basically treat with ACLS, give him some oxygen, and find the closest place to recompress him. Because he's unconscious, we can't actually, sometimes when people are conscious, we can actually recompress them by just going down, let's say, 30 feet in 10 meters in the water, as long as they're conscious and doing fine. If they're just having maybe some musculoskeletal or type 1 decompression sickness, but somebody who's obviously unconscious or unstable, you cannot do that. But the patient may also have a pneumothorax. He may have I'm trying to think of other things. May have some neurologic complications from decompression symptoms, like type 2 decompression sickness, sorry. So there's a few things that he may have, but I'd be most worried about ACE. So some good vital signs, airway, breathing, circulation, and getting him recompressed. Okay. Any questions? Of course, I can't answer them now, but feel free to write some questions down. I'm happy to answer them whenever we talk on Thursday. I don't know what time it is for you, but I know that for me, it's going to be 2:30 Mountain Time, p.m. So this Thursday, I look forward to our chat, and I have, let's see if I can pull this up. Oh yeah, here we go. I'm gonna go down. All right, bye. In case you guys don't have to watch this is probably really silly and stupid, but I found this thing. Whenever I think of diving or giving lectures on dive medicine, I always think about the movie The Abyss. I watched it when I was a kid and I thought it was really awesome. It's really not that awesome, but watching it now as an adult, but there's this awesome clip that I found on YouTube and I figured I'd just play it. It's only like about 2 minutes long. So feel free to sign out. Don't watch this if you don't have time. Otherwise, just for your entertainment, here we go.
Okay, these are so your eyes can focus on the breathing fluid. How's that feel? There it is. If you can't see, you can't disarm the bomb, right? Okay, with this much weight, you're gonna fall like a brick. We still got about an hour, so we should get there in plenty of time. When you get down there, all you gotta do is cut one wire, drop the weights, and come on home. Hand me that wrench over there. Maybe I ought to check.
I forget why he's doing this, but he has to save somebody or something. And there's no one else who can do it. You can tell that this girl sure as hell is not going to do
You
it.
don't have to do this.
Somebody's gotta do it.
It doesn't have to be you.
Who then?
Yep, not her.
So I can hear you, but I can't talk, right?
The fluid prevents the larynx from making sound, excuse me. It'll feel a little strange.
Yeah, no shit. I gotta warn you all. I'm a pretty lousy typist. Moment of truth. Come on, let's go. Let's go.
Easy.
So we have to put this thing on his.
In the front of it.
We have to put this thing on his head, and then they're gonna like put this like amniotic fluid around him so he can breathe that in, and that's gonna give him oxygen. Interesting. Not actually medically relevant, but or possible, but it's an interesting thought. And I guess it would prevent against like some
Okay,
sort of
let's rock
like
and roll.
decompression. Some lung trauma, lung barrel trauma.
Headset.
Here it goes.
Okay.
Relax now, bud. Just relax.
Bud.
Relax now, bud.
Watch me.
Relax.
Okay, watch me. Watch me.
Okay, doing fine. Now, don't hold your breath. Take it in. Just let yourself take it in. Take it in. That's it. Oh, man. Don't hold your breath now. Take it in. There you go. Don't hold your breath. Take it in. That's it. There you go. What? That's normal. It'll pass in a second. It's perfectly normal. It's perfectly normal.
It's so good.
We all breathe liquid for 9 months, bud. Your body will remember. That's it.
No.
That's it. Perfectly normal. Christ, he's breathing.
Give me that. Can you hear me?
There he goes.
Yes.
He's got
Yes.
it.
Okay.
That's it.
Bud.
That's it. All right. I'll pull my picture back up. All right. Kind of funny. I like it. But I'll see you guys on Thursday. We'll chat on Thursday. Looking forward to it, guys. Let's see how I can get this thing down.